All right, thanks very much. Appreciate being asked to talk about this topic. Just a quick point of clarification, it should be growth-friendly rather than growth-sparing. Bruzak Barnia put in a lot of work a few years ago combining some terminology with POSNA, SRS, and the study groups, and we're trying to be consistent with our terminology. So I'm going to stick to growth-friendly. Feel free to if you'd like. I'm going to talk about MCGR and how to treat hyperkyphotic patients. This is an 8-year-old girl with cerebral palsy back in 2015. You can see clinically she's very hyperkyphotic. On her radiographs, there is an element of flexibility as she is being held upright for the x-ray. Keep in mind that with early onset scoliosis, it's not just thoracic kyphosis, it's often a global kyphosis with a slightly lower apex of deformity. So this girl was treated with MCGR from upper thoracic to the pelvis. And you can see that acutely she did have some correction in her kyphosis and was able to maintain that over 3 years. And why is this happening with MCGR? Whereas with other types of devices, it might lead to more increase in kyphosis. So why do we care about kyphosis? Well, the main outcome that we're looking at is PJK, as Laurel had mentioned. Lots of different definitions of PJK, and I think the most agreed upon, without putting any numbers on it, is it's a non-physiologic sagittal plane angulation that occurs cephalad to the instrumented spine. The Children's Spine Group did look a few years ago at traditional growing rods and found that 27% risk of PJK, essentially the same regardless of what type of anchors are used, and higher pre-op kyphosis increased the risk of PJK. What the group felt was that by having higher thoracic kyphosis preoperatively, if you correct them acutely and you improve that kyphosis, the patient still wants to kyphose somewhere. So as a result, there is a moment arm where they do want to bring their head forward. They'll lower dose their cervical spine to try to compensate for it, but over time, as the muscles fatigue, you lose that ability to compensate. And as a result, with at least 2 years follow-up, that cervical lordosis leads to an increased proximal junctional angle. So there's an increased angle at the top of the construct and just above it. And then that increases your sagittal vertical axis. So you end up having more force anteriorly. And as a result, that leads to proximal junctional kyphosis. So just going through that, if you've got hyperkyphotic, correcting the kyphosis too much can lead to problems with traditional growth-friendly implants. This is particularly true with the first generation of the rib-based constructs, in which the kyphosis increases with each lengthening from 40 degrees to 65 degrees. And a lot of that is related to the radius of curvature of the device. And I'll get to the MCGR in a couple of minutes, because the design of the MCGR is different, that the traditional rib-based had 70 millimeter radius and then a 220 radius of curvature. 500 radius of curvature was designed to address the kyphosis found with the 220. So if you compare these side to side, this is before any lengthening is imparted on the device. This is a 220 radius and this is a flatter rod of 500. If you go ahead and lengthen these, it doesn't just lengthen in one plane, it lengthens in both planes. It follows that arc of curvature, so it does increase the kyphosis. And I'll show you some MCGR images that does not happen with that particular device. Pernandu Gupta and some other collaborators did look at the risk of PJK for patients being treated with MCGR and presented it at this meeting last year. And with at least 2 years follow-up, 67 patients, they did not find any difference in the kyphosis over time. It stayed at about 28 or 29 degrees preoperatively as well as postoperatively at 24 months. And the risk of PJK that Gupta found was was only 12% risk of PJK, and 3 of those 4 patients did have increased kyphosis. So increased kyphosis preoperatively can affect the risk of PJK in MCGRs, but it seems that that risk is a little bit lower than it might be with traditional implants. There's also some implications on looking at the PI-LL matching and also the sagittal vertical axis. And also, we're looking at the position of the actuator, where that flat part of the MCGR is with respect to the thoracolumbar junction, how high it might be or how low it might be, which might affect the contouring of the rods. We're studying the arc of curvature of the rods as well, above and below the actuator, to see if that has an impact on long-term kyphosis and PJK. So we all know what's unique about the MCGR. There is the actuator geometry. It's straight. You cannot contour it. So by default, you do not have kyphosis in that flat region. What you care about is what happens above it. So here's a patient who had increased kyphosis, an 8-year-old with SMA preoperatively. And immediately post-operatively, there's still a fair bit of kyphosis built into it. But 3 years later, just by the straight geometry of the actuator, the kyphosis has been improving with the MCGR. So if you're comparing the MCGR on the far left to the other implants that we looked at before, even with a lot of kyphosis above it and with the actuator a little bit lower at the thoracolumbar junction, when you go to lengthen those devices, you follow the arc of curvature with the other devices, but the MCGR, that just goes up in one plane. So even if you have an acute curve up here, the actuator just drives everything up in one plane. So potentially just by keeping that actuator lower and accommodating for the kyphosis in your rod contour, that may improve the hyperkyphosis over time. So the strategies for managing hyperkyphosis, you want to avoid acutely correcting the hyperkyphosis. We talked about that mechanism where you improve it, the body wants to go forward, and you'll end up with PJK. Take advantage of the straight actuator. You can also look at the number of anchors as well. That increases the stability and hopefully will resist any implant pullout as the body does want to go anteriorly. Shorten the working length of the spine. So we'll go through these very quickly here, one at a time. This is that first girl with cerebral palsy with the hyperkyphosis. By acutely contouring the rod intraoperatively with the lordosis and the kyphosis and matching that with fluoro and then inserting the rods, you end up with this type of result where you're following the kyphosis intraoperatively, and then with growth over time, it can improve or at least not create hyperkyphosis like you saw with that first generation rib-based implant. Number of anchors with this patient, we've heard from Skaggs and Vitale that the number of proximal anchors does resist pullout, and that should help combat clinically significant PJK. And then finally, shorten the working length of the spine will increase the rigidity of the construct. So the working length is the unsupported part of the spine. So you don't have any anchors from here to here. That's much less in this patient than this patient over here, and that should help maintain that contour. And we can just jump through this. And in conclusion, I think we've demonstrated that hyperkyphosis can be managed effectively with MCGR. You can still use all the strategies that Laurel had talked about for traditional growing rods to help out as well. But take advantage of the shape of the actuator and the ability to contour the rods into kyphosis above it. And with time, that may improve the kyphosis. Use the number of anchors and the working length to your advantage to try to maintain that sagittal plane. Thanks.